Every good treatment starts with one thing: an accurate diagnosis. Before we can help a patient heal, we have to know exactly what we're treating and why. In medicine, it's tempting to jump quickly to solutions, to prescribe, to operate, to fix, and in some cases just to say, well, there really isn't a problem. But the most important step, and the one that determines whether care succeeds or fails, is the diagnosis itself. Obviously, an inaccurate diagnosis or incomplete diagnosis can send the entire treatment down the wrong path. The most sophisticated procedures, technologies, and medications can only succeed if they're directed at the right problem. So, before we plan surgery, order therapy, write a prescription, or discharge somebody from the ER or our clinic, we need to start with the most powerful tool we have: clear thinking, careful evaluation, and an accurate diagnosis. I want to share with you two cases that illustrate this principle. Both patients presented to me in the emergency room with a lumbar MRI. This patient originally presented to the emergency room about 3 days before I first saw her. She had lower back pain and was struggling with the pain, which is what brought her to the emergency room. She had normal vital signs. Her back MRI showed degenerative changes at L5S1 and mild degenerative changes at L4-5 without any evidence for stenosis. She was given some pain medication and discharged home. Later, the patient began having a fever and was admitted to the hospital. Labs showed elevated ESR and CRP. A repeat MRI with contrast showed that while the patient does have degenerative changes at L5S1, she has an infection of the disc and the formation of epidural abscess. We ended up taking her to surgery to drain the epidural abscess. By the time she was fully diagnosed, she was having more leg symptoms and even some weakness in her legs. At surgery, we drained a large volume of pus from her back and initiated the antibiotics. Discitis and osteomyelitis can be one important diagnosis that we should not miss and can be a challenge to make, as some patients appear to have degenerative changes but really have the early stages of discitis. Patients with discitis almost always have severe back pain. Not all of them initially at least present with fever. If you have any clinical suspicion for discitis, ESR and CRP can be very, very helpful to rule out discitis. The MRI is quite accurate but needs to be given with contrast. Always want to be looking for risk factors. In this patient, she had the port and the history of cancer, which may have caused some immunosuppression. This is another case. This is a 65-year-old woman who presented with some lower back pain and on exam had bilateral lower extremity weakness at about 4 out of 5. She also had mild hyperreflexia. On her lumbar MRI, she has a degenerated disc at L4-5. I did not see any significant neuroforaminal or central canal stenosis. She's in the emergency room, obviously complaining of lower back pain, but the lower extremity weakness is not explained by this MRI. I recommended to do a thoracic MRI, and on that study found a large meningioma that caused severe spinal cord compression. On the axial views, we can see the spinal cord here, and then as I scroll down, there's the tumor, and the spinal cord is a thin ribbon pushed by the tumor over to the sidewall of the spinal canal. So we removed the tumor and her leg symptoms improved. So I intentionally picked these two cases because a possible missed diagnosis could have led to devastating consequences for the patient. And we should have that mindset. If we miss something, it could lead to harm for the patient. So the message really is to slow down, to listen to the patient's story, to become curious, to ask the right questions, and to constantly seek to make the most complete and accurate diagnoses that we can.